Good afternoon, everyone. So today we are having a very useful discussion on complications of PCI. So to start with, the understanding and addressing of various complications of PCI is critical to the practice of interventional cardiology. It is also very critical to appreciate and explain the possible complications of PCI to provide proper informed consent to the patient. And we have to be very vigilant and recognize the potential complication at an early stage to try to reverse an adverse outcome possible out of the procedure. Some of the complications are generic to all coronary angiographic procedures, while others are specific to coronary intervention. So events such as death, MI and bleeding occur at higher rates for interventional procedures because there is a direct manipulation of coronary arteries, often accompanied by prolonged procedural time, complexity and use of higher intensity anticoagulation. And complications of PCI can occur at any step of the procedure, from the administration of sedation to transfer as the patient leaves the laboratory. So this is just the tabulated version of various complications and its event rate in diagnostic procedure vis-a-vis interventional procedure. So you can see that the incidence of all the different complication is somewhat higher in the interventional procedure as compared to the diagnostic procedure, because in interventional procedure there is a direct handling of the coronary arteries. So these are some of the complications which are specific to PCI. Chiefly among them are the no-reflow phenomenon, stent thrombosis, vessel perforation, stent embolization, need of emergency surgery, wire fracture and stent infection. So to start with mortality, it is the most serious complication of PCI. In-hospital mortality is very rare with a diagnostic procedure, but the rate exponentially increases with the addition of intervention. And the mortality rate greatly varies depending on the urgency of PCI. And besides the clinical acuity, the higher age, the history of renal disease, history of cerebrovascular disease, history of peripheral arterial disease, history of COPD, diabetes, heart failure, lower ejection fraction, cardiac arrest within 24 hours, patient with STEMI or having a BMI more than 30 are all independent predictors of mortality. Second important complications are those which are associated with vascular excess and bleeding. So the first part of any procedure begins with a vascular excess. So the chief complications are basically femoral artery pseudoaneurysm, arteriovenous fistula and bleeding. Various risk scores and calculators have been used to assess the risk of bleeding with independent predictors including advanced age, small BMI, chronic kidney disease, baseline anemia or vascular excess site, sheath size and number and type of antiplatelet agents and anticoagulants which are used. Another important complication is pseudoaneurysm. So femoral artery pseudoaneurysm represents the failure of sealing of the initial arterial puncture site, allowing the arterial blood to flow into the surrounding tissue. It forms a pulsatile hematoma which acts as a covering roof of the aneurysm, and basically they are associated with local pain and swelling and diagnosed with femoral ultrasound with an excellent sensitivity. Small pseudoaneurysms are often closed spontaneously, while large pseudoaneurysms or in small ones that also fail to close, active treatment is necessary. The two common most modalities are the ultrasound guided compression or thrombin injection. Excess site complication, particularly in the case of risk factors for pseudoaneurysm. So there are certain risk factors for formation of pseudoaneurysm. Procedural are like catheterization of both arteries and vein, cannulation of superficial femoral or profunda femoris, inadequate compression post procedure or more anticoagulation which is used. And certain patient related factors are also important for pseudoaneurysm formation, that is obesity, hemodialysis and calcified arteries. So this is just a picture of how to treat the pseudoaneurysm with thrombin injection. So it can be directly performed by inserting a syringe in the pseudoaneurysm which is ultrasound guided, and the dilution which is we used is 1000 unit of thrombin into 1 ml of syringe. And rarely in very large pseudoaneurysm and which are resistant to thrombin injection, surgical options are often required. Second important excess site complication is AV fistula. So it is characterized clinically by a palpable thrill or an audible bruit, and conservative treatment with watchful waiting is the most common treatment modality. 1/3 of persistent AV fistula will close during the first 12 months, and about 10% of AV fistula will ultimately require surgical repair. The main risk factor for the development of AV fistula is a low arterial puncture, which is responsible for almost 85% of all AV fistulae. So this is just the picture of that AV fistula, where This is the cine angiogram of the arteriovenous fistula. Contrast visualized in the vein returning cranially indicates a communication with the artery. Another important complication is the bleeding. So most dangerous complication of groin excess is major femoral bleeding. Large femoral hematoma have an incidence of 2.8% compared to 0.3% incidence of retroperitoneal bleeds. So a retroperitoneal hematoma is often requiring blood transfusion and prolonged hospitalization and often associated with very higher mortality. So which are the significant risk factors for such catastrophic complications? Chiefly are the extremes of age or overuse of heparin, severe renal impairment, or extremes of like a female patient is there, device closure use, or higher sheath size during the vascular access, use of GP2A inhibitors, and longer procedural duration. So which are the classical signs and symptoms of retroperitoneal bleed? Chief among them are the hypotension, bradycardia, back or flank pain, abdominal pain, transient response to fluid loading, Gray Turner sign and Cullen sign. So if a retroperitoneal bleed is suspected, a volume expander should be given and blood should be ordered immediately for transfusion. Surgeon should be consulted immediately, and ultimately a surgical or endovascular repair may be needed. Most of these are caused by bleeding from an external iliac artery above the inguinal ligament or inferior epigastric artery. Another important complication is infection. So proper sterile technique including hand washing, use of hats, masks, gowns and gloves has limited the incidence of bacterial infection. Routine antibiotic prophylaxis is not recommended before catheterization. However, if there is any concern of contamination of femoral sheath, it is standard to give 1 gram of cephalexin as a prophylactic measure. Equally concerning infectious complication is exposure of physician or staff to the patient's potential pathogens. Another important complications are related to atheroembolism, primarily are stroke, periprocedural MI and cholesterol embolization. So advancing large bore guiding catheters or even 6 French catheter across a porcelain aorta which is laden with atherosclerotic plaque is highly prone to cause thromboembolic events resulting peripheral ischemia, renal failure or stroke. Intracoronary atheroembolism is an important mechanism of periprocedural MI. And besides the intracoronary atheroembolism, other causes of periprocedural MI include occluded side branches, no-reflow, vessel perforation, vasospasm, acute stent thrombosis and dissection. And the management of periprocedural MI depends on the underlying cause. Now talking about the cholesterol embolization syndrome, it's having an incidence of 0.75 to 1.4%. It is diagnosed typically by one of the 3 typical cutaneous signs, which is the livedo reticularis, blue toe syndrome or trash foot or flank digital gangrene, in addition to laboratory evidence of an elevated eosinophil count. So in hospital mortality is as high as 16% in those with definite cholesterol embolization syndrome, because multi-organ embolization can lead to multi-organ failure. So this is just the picturesque form of the different manifestations of cholesterol embolization syndrome. Talking about the coronary dissection, the guide catheter itself can cause coronary dissection with or without extension to the aortic root, and more commonly coronary dissection is caused by advancement of the coronary guide wire or by balloon inflation. Stenting the dissected area remains the standard of treatment, and a guide catheter which is ostial or proximal dissection should be fixed before proceeding to the intended PCI lesion. So there are different risk factors for coronary dissection. Chiefly among them are the left main disease, use of Emplar's catheters, acute MI, extensive catheter manipulation or vigorous contrast injection or deep intubation of the catheter within the coronary artery or variant anatomy of the coronary ostia. So talking about the classification of the coronary dissection, it typically classified in A to F. Sequentially they are luminal haziness or linear dissection, type C is extraluminal contrast staining, type D is spiral dissection, E is dissection with persistent filling defects, and F is dissection with total occlusion. So this is just the detailed description of the different types of dissection, and corresponding angiographic projections are also seen. Talking about the coronary dissection extending into aortic dissection, it is a very rare complication. Almost all cases of retrograde aortic dissection are from the right coronary artery. It is classified into 3 classes. Class 1 which involves the ipsilateral cusp, class 2 involves the ipsilateral cusp and extending up to aorta less than 40 mm, and class 3 which involves the aorta more than 40 mm. So class 1 and 2 are having a good prognosis and can be treated by stenting. Class 3 lesions are generally should be treated surgically and associated with higher mortality rate. So contrast media complications, so intravascular radiographic contrast media can be associated with anaphylactic reactions and acute renal failure, and incidence is 0.23%. So risk factors for an allergic reaction to radiographic contrast media includes prior reaction and history of atopy, and individuals at risk of an anaphylactic reaction require pre-medication. So prednisone 60 mg should be given the night before the procedure and the morning of the procedure, and Benadryl 50 mg IV should also be given up to 1 hour before the procedure. So this is just the treatment of the various anaphylactic reactions in the cardiac catheterization laboratory. So for the most severe reaction, the bolus epinephrine is given, which is prepared by mixing 0.1 ml of 1:1000 solution and producing a final concentration of 10 microgram per ml. If the patient have taken recent beta blockers, in that case you might have to give glucagon in addition to epinephrine. So talking about the contrast induced nephropathy, it is defined as relative increase in the serum creatinine of more than 25% or an absolute increase of more than 0.5 mg%. Increase in creatinine starting in 12 to 24 hours for most patients, but it may take as long as 48 to 96 hours to peak. And most cases show a return to baseline creatinine by days of 3 to 5, but can take up to 7 to 10 days. So the prevention of CIN chiefly consists of adequate hydration and limitation of the volume of contrast administered. Use of isoosmolar contrast agents, sodium bicarbonate, IV fluids and N-acetylcysteine are also effective. So air embolization, which is a iatrogenic complication due to failure of clearing the air from the injection manifold system. Treatment consists of initiation of 100% of oxygen, and it helps minimize ischemia by producing a diffusion gradient. So if large bubbles still persist, the air can be aspirated by various aspiration catheters. So talking about the arrhythmia, unstable arrhythmias like VT and VF or bradycardia are often common in cath lab, mostly in the setting of STEMI, and in bradycardia is most common with RC occlusions. And treatment of arrhythmia should follow the standard ACLS protocols. Talking about the no-reflow, it's an acute cessation of coronary flow during the PCI as a result of abrupt occlusion or a distal outflow failure, and most commonly it is seen in infections on graft as well as in STEMI patients. So the treatment of no-reflow depends on the underlying cause. If it is due to thrombus or plaque rupture, catheter aspiration is important in addition to GP2-1 inhibitors. If it is due to dissection, stenting is needed. If it is due to severe spasm, intracoronary nitroglycerin is given until it is relieved. So this is just the flow chart for treatment of the no-reflow. So it depends chiefly on the cause, and the different pharmacological treatment which can be given in no-reflow includes adenosine, nicardipine, epinephrine, nitroprusside and verapamil. And ultimately in the resistant cases, we might have to consider the use of IABP or circulatory support. Another important complication is coronary perforation. Its incidence rate is almost 0.8%, and it is classified. Ellis has given the classification of coronary perforation in 3 classes. Class 1 is a crater extending outside the lumen and in the absence of linear staining angiographically. Class 2 is a pericardial or myocardial blush without a 1 mm exit hole. Class 3 is frank streaming of contrast through a more than 1 mm exit hole. In class 3 with cavity spilling is perforation into the anatomic cavity chamber or coronary sinus. So depending on the, this is just the graphical representation of the different types of perforation. And class 1 and 2 perforation are usually managed conservatively, and class 3 are associated with rapid development of tamponade, the need of urgent bypass and higher mortality rate. So for the treatment of type 1 perforation, it is usually not requiring any active treatment, but in the case of some cases we have to inflate the balloon at the perforation site with low pressure, and it might need a second coronary stent, and a check angiogram should be needed to ensure the non-progression of perforation. This is a type 2 perforation. So it is similar to type 1 in the management, but it is associated with higher rate of progression to type 3. Myocardial blushing is considered a lower risk than the pericardial staining. So in the treatment of type 2 perforation, it's more or less same with the type 1 perforation. This is a frank type 3 perforation with spilling into the open spilling into the pericardial cavity with a more than 1 mm exit hole. So in that case, if the patient is having hemodynamic instability, you have to call for urgent help and prepared for pericardiocentesis. Meanwhile, we have to inflate the balloon at the perforation site with low pressure, and ultimately we might require a covered stent or various other alternatives like mesh stent or another DES or BMS stent, which is but covered stent is most commonly used. If it is non-sealed with cover stent, also reconsider the site of perforation and is the cover stent under expanded, you have to initiate the NC balloon at the site of covered stent and consider a second covered stent, and ultimately in resistant cases we might have to consider surgery. This is a double guide catheter technique which is often used in the treatment of type 3 perforation, where simultaneously another guide is taken, wire is advanced, and covered stent is taken over the second wire. So type 4 perforation, which is checking for hemodynamic instability, and then ultimately we have to call for help and inflate a low pressure balloon, and ultimately if there is extravasation into a low pressure cardiac chamber and in a hemodynamically unstable patient, most of these patients are stable because the dye is staining into some low pressure cardiac chamber, but if the patient is hemodynamically unstable, we have to cover it with covered stent. This is the type 5 perforation, which is initially missed as it is because in the distal leak is there because of the coronary wire. So in this case the leak is often small and may require panning to the distal vessel, and management may require embolization of the distal vessel with thrombin coils or fat. So for the treatment of type 5 perforation, the initial algorithm is almost the same, but in the last part, if it is failed to seal, then we have to embolize it with a thrombin, microcoil or fat embolization, and ultimately we in the resistant cases we might have to consider surgery. So these are the different covered stent which are available widely in the market and are commonly used for coronary PCI. The most commonly used is the Graph Master by Abbott, and it is ranging in diameter 2.8 to 4.5 and compatible with 6 and preferably 7 French, and it is very much commonly used. Talking about the autologous subcutaneous fat embolization, so it is used for distal guide wire perforation, and it is basically giving a physical barrier to bleeding, simple and low cost and universally available treatment, and allow for subsequent PCI attempt also. So in this case, the fat from the abdominal or the femoral area is taken under local anesthesia, and the fat globules which are small enough to deliver through a thromboaspiration catheter or with a microcatheter or over the wire balloon and they are pushed by the wire or immersion with saline serum injection. Catheter is positioned just close to the perforation to avoid a large periprocedural infarction or systemic or cerebral embolization. Talking about the coronary perforation by coil embolization, in that case they are not necessarily available, need expertise in the use but not difficult to perform. Detachable coils and pushable coils are available, which are delivered through a usual coil through a microcatheter, a fine cross or a Terumo. Important another complication is entrapped PCI components, which is maybe guide wire tips or balloon system or parts of various catheters, and they carry the risk of coronary artery occlusion, distal embolization, perforation, infection, ischemia. So ultimately removal is necessary. So this is the snare which is used for retrieval of intracoronary ficta fragments. The B panel in the B, the left panel is showing the snare which is snaring the stent. In another one is capturing a free stent, and in the right panel it is capturing the catheter fragments. So this is the showing double wire technique for treatment of this, and in this case it is showing the two guide wires which are entering the single Y connector through a single torquing device, and they are torqued together forming a helix which travel distally, and ultimately it is used to snare the trapped fragment. This is just a overview of the different flow chart to remove the trapped wire or broken stent or burr or for the microcatheter respectively. So ultimately in this case the previously described techniques have to be used, and you have to be extra cautious in early detection and its treatment. So this is just the table which is giving an overview of the recommended resources for the management of PCI complications. So a pericardiocentesis tray, a covered stent, coils and microcatheters, snares and thrombin or microspheres. And in the hospital we need to have cardiothoracic surgery, a peripheral vascular, echocardiography or experienced cardiac ICU. So stent thrombosis, as we all know, it's a very rare and devastating complications of PCI with a very high mortality. Typically it is classified according to the temporal, like it's acute, subacute, late or very late. And the risk factors for stent thrombosis are premature discontinuation of antiplatelet therapy, incomplete stent expansion, greater stent length or subtherapeutic periprocedural anticoagulation, cocaine use, prior brachytherapy, post-procedure TME flow grade 3 and treatment of bifurcation lesion. So this is just the ARC criteria for stent thrombosis: definite stent thrombosis, probable and possible stent thrombosis. Another important complication is a stent infection, which is the rarest complication of PCI stent infection, which is usually presenting as mycotic aneurysm or persistent bacteremia. Staph aureus is the most common microorganism which is implicated, and the stent infection usually present within 4 weeks after stent implantation, and typical findings of chest pain, ECG or other biomarkers might be absent. High degree of suspicion is required, in particular any fever occurring within 1 month of PCI. So which are the avoidable and unavoidable risk factors? Chiefly among them are the difficult vascular access or multiple skin punctures, repeated catheterization or extended duration of the procedure, use of multiple PTCA balloons, and deferred removal of the arterial sheath. Unavoidable risk factors are the presence of congestive heart failure and elderly patients. Confirmation of the diagnosis may be difficult with imaging, and besides antibiotic therapy, most cases will require surgery. Thank you.